the F word, as you put it, it's not really inclusive of the full like stuttering experience. And so it's kind of misleading, and it kind of paints sort of this weird binary where it's very black and white. It sort of just perpetuates this kind of false narrative that we've built up about what the goal of even stuttering therapy is.
Welcome to Some Stutter Law, Newfoundland and Labrador's first podcast about living with communication differences. It is a production of the Communication Collaborative and is in solidarity with the Newfoundland and Labrador Stuttering Association. My name is Greg O'Grady, and I am a person who stutters and your host. Some Stutter Law is a unique opportunity for us to discuss topics, experiences, and perspectives on what it is like to live with communication differences. To live with a disability, but also to uplift and inspire, to rebuild confidence through inclusive language and themes, and to install hope by dismantling myths, stigma, stereotypes, and barriers surrounding speech, language, and disability challenges. Some Stutter Law is a safe space to speak and to own your truth, a safe space to communicate differently without the fear of being judged or feeling shame. If you only get one thing from this podcast, we hope it's this. It's okay to stutter, and it's okay to communicate differently. It's not how we communicate that's important, it's the message that's important. So let's communicate differently without the need to ask permission or to apologize for being you. For more information about the Communication Collaborative or this podcast, you can find us at somestutterlaw.ca. This morning, Some Stutter Law welcomes Terry Campbell. Terry is a speech-language pathologist based in St. John's, Newfoundland. He works for Coastal Health, a private practice that has an interdisciplinary team of healthcare professionals dedicated to community wellness. Terry was originally with the teletherapy company Tiny E, working with school-aged children, and just accepted a position with Eastern Health, working in acute care at the moment. Terry has a diversity of speech-language clinical interests, transgendered and gender-affirming voice services, voice disorders, swallowing disorders, dysphagia, aphasia, Parkinson's disease, motor speech disorders, fluency, stuttering, and dementia, etc. He is passionate about helping people who stutter and has a professional interest in the social and emotional experiences of those affected by stuttering. He was recently elected as a board member of the Newfoundland Labrador Stuttering Association Board of Directors. Congratulations, Terry.
Thank you.
Terry is excited to be a member of the NLSA. Terry is honored to have a role in their continued support for people who stutter and their families. So welcome again to Some Stutter Law, Terry.
Oh, thank you. Thank you for the kind introduction there.
Terry, with the plethora of your communication disorders interests, why have you decided to focus on these areas?
Yeah, that's a great question. I think that there's a lot of challenges within each of them. And for me, I'm the kind of person that, I love a challenge, and there's so much variation within each of those areas. So I think about, for example, Parkinson's disease and the voice challenges that somebody with Parkinson's disease might experience. There's a lot of different approaches, and there's a lot of different techniques and things that you might need to try out in order to find what fits for a particular person. Same thing with transgender or gender affirming voice. Swallowing disorders can be really tangly. Doing swallowing assessments, that's always kind of a really big. There's a big investigative kind of component to that. And so with stuttering, the thing that I find the most fascinating about stuttering, and you'll be able to speak to this from as a person who stutters, is just how multifaceted it is. And I think stuttering is sort of one of those communication differences that's so uniquely positioned in that, like any communication difference or disorder, or however you frame it, it can affect so many different factors in a person's life. So it can affect how you perceive just communication in general with other people, whether you find pleasure or displeasure in it, um, your whether or not there's any kind of mental emotional component that you feel is tied directly to your stuttering or your stuttering experience. There's just a kind of like this web that sort of expands out from just the observable stuttering that a listener might see, that we don't often think about, that we and that as a person who doesn't stutter like myself, that I just don't have a good understanding of it even now. I'm getting better, at it, and I'm as an SLP, I'm certainly more aware of it in terms of assessment and working with people who stutter. But it's still one of those things, as a person who doesn't stutter, I'll never really fully understand. And I think because of that, it's very humbling, and it's sort of what drives me to become better as a clinician, but also even just as a person, to just try to better understand the position of people who stutter, because it's so it's just so unique. The difference, for example, between somebody who has aphasia or Parkinson's disease, while both of those are absolutely challenging, and both of those are I'm not trying to diminish, and I'm not comparing communication disorders to one another. But what's unique about stuttering is that it affects the experience of the speaker from birth, from the time that they start communicating. Typically, there's your typical childhood development or childhood onset, whereas Parkinson's disease or aphasia, the difference is that prior to an event occurring, or prior to the onset of a disease, you had an experience as a communicator, assuming you were a person who didn't stutter, um, that was more fluent, if we're kind of using that binary. Um, so I think that that's what's unique, is that it's just so ingrained in the person who stutters experience, like from the get-go, as opposed to the person who doesn't stutter for a very long period and maybe has a stroke and all of a sudden has a communication
Mm-hmm.
challenge. So they're both very challenging in their own way, and again, not comparing one to another in terms of severity or of experience, but I think that's why I find those areas so fascinating, is because they really require such a unique approach in either way. But stuttering in particular is just so fascinating to me
Mm.
in that respect as a clinician. Um, yeah.
Great, great, Terry. Well, Terry, I sense that that you may have answered my next question.
Oh, okay.
Is there one specific communication disorder you plan on specializing in, and if so, why? And I sense you're really passionate now, or have a strong interest in stuttering. Am I correct?
Yeah, I do have a strong interest in it. I wouldn't say, I don't want to limit myself and say like, oh, I'm going to be like, this is going to be my bag, like this is what I'm going to do, because I think I'm at the stage in my career where it's kind of, I the demand on me is to really be a generalist, in terms of like, if I'm working in acute care, if I'm working in private practice, I sort of have to be prepared for anything. And so there's certainly areas that I do want to become strong in, and certainly become better in, fluent. Like, I would say that stuttering is absolutely one of those areas, in addition to voice, voice disorders, or transgender, gender affirming voice services. Um, and I would say, yeah, like all of those areas that you listed previously, those are definitely things that I would love to become really strong in. So that if somebody was coming to me for therapy in a couple years' time in private practice, then they could see me as, oh, this person specializes in XYZ. So yeah, I feel that your statement is accurate in that respect, I would say. Yeah.
Okay, Terry. Terry, I'm looking at an outline here, and I have to apply all speech language pathologists because speech disorders fall under the umbrella of communication disorders, and
Mm,
this umbrella plus feeding and swallowing is an entire field of speech language pathology. I'm looking at
yeah,
communication disorders which involves feeding and swallowing, speech delay, languages,
yeah,
articulation. It's just a huge field, and Terry, and then you involve fluency disorders like stuttering, developmental neurogenic cluttering, speech production. And that's a lot for any a speech therapist to absorb. And I guess it,
it is.
and so
Yeah.
what would be the challenge there to actually like in terms of trying to identify what treatment programs are appropriate? I mean, that's the wealth of
Yeah. Oh, you're absolutely right. And it is challenging. And I think once I graduated, I kind of, we're sort of taught in school, like we cover all of the areas and we cover them just enough so that it feels like if we're thrown into the situation, we're not floundering, we're not drowning, like we're ready, like we have at least some kind of foundation to draw from. Um, but absolutely, like when you're out there working, like following graduation, it really felt like, okay, I need to take stock of what my strengths are, and I need to take stock of what are maybe some areas I need to work on that are relevant to the work that I'm doing right now. And so, yeah, it's very challenging. So, for example, um, I felt that after graduation, my experience working with peds was probably, if I had to kind of compare it on a level with working with adults and more kind of acute care or even inpatient, outpatient sort of hospital services, I would say like that was probably a bit higher than my ability to work with peds down here. And so I really had to think about, okay, what can I do to really sort of bring that leveled up a little bit so that way if I am in a situation working with a pediatric client, that I'm able to kind of more readily adapt to that. And it is very overwhelming because there's just such a huge scope of practice. I would say too, kind of on the theme of today as well, is that within all of that, swallowing, communication disorders, everything you listed, um, there's also a counseling component that's within our scope of practice, um, which is also really interesting. And certainly that it's within our scope of practice, but within our lane as well. So we're not like a trained psychotherapist or a social worker or anything like that. But there's a big counseling component to all of that kind of drapes over the entirety of what we do. That's sort of always present when you're interacting with a client as well, which is really important. Yeah.
so Terry, how long have you been a speech pathologist now?
So I've been a speech pathologist technically since August of last year is when I finally got registered.
Mm.
Like after passing the exam and everything, so I passed the exam to be certified and registered as an SLP back in July of last year. So not very long. So I'm very green. So I feel like as a kind of like a preface to everything I talk about today, I want to let the listeners know, like I am a newly minted SLP, so I'm sure there may be other SLPs if they're listening today. If there's information I'm kind of putting out, they may have different opinions or different professional opinions, and I would certainly welcome those because I'm still learning and all of those
Mm.
things. But yeah, very new to it, and I think that's what's really exciting to me about it because prior to becoming an SLP2, as a little background for your listeners, I was a music teacher and I was a professional musician full time. That's what I was doing for many years. And so I really loved working privately with students. I loved gigging and doing all of those things, but I was looking for a change. And so that's when I switched to becoming an SLP, and I absolutely love it. It's just a huge challenge, and that's what's exciting about it. It's like there's just new stuff for me to do, and like new things to kind of work on and focus on, which is really fun. Yeah, and it can be definitely challenging, but I think that's what's great about being newly minted, and I'm like not even at a year yet, and still loads to learn and do, which is really fun.
Well, but being green as you call it, Terry, is important because like I feel that within the profession we need new eyes, we need new insight, and that helps. That goes a long way, you know.
Oh, oh yeah, no, and that's great to hear too. Yeah, because it's what's interesting too. Like, since I'm kind of like newly graduated, I'm from an SLP perspective. There's a really interesting thing that kind of happens between like we're within the assessment process now, and kind of comparing that to what's happened in the past. And this has actually come up a little bit, I think, I'm sure in other conversations you've had, is that on the podcast and elsewhere, where the focus of assessment now from an SLP perspective is has shifted so much more, and I'm talking in sort of broad strokes in general, has shifted so much more to the perspective of the speaker. And so, as in terms of the person who stutters and their experience. So there's like something I was hoping to talk about just very like a little bit today, and I feel like it's so tied to, or like to what that topic of mental health and emotional well-being and the person who stutters and their experience, and that there's something that kind of that used to occur quite a bit in past assessment where the big emphasis was on like disfluency counts. I don't know if you're familiar with this at all. Um, but when a person who stutters in the assessment, so as an SLP, you would sit down, have them read a passage, or you would get a speech sample, and then you would count the amount of times that the person stutters, and you would say like, okay, out of 300 syllables, there were like so many stuttering events that occurred, and then you'd come up with a percentage and say like, they were 14% disfluent or whatever. And what's really funny about that is that in no way whatsoever is reflective of the person's experience. And it's
Correct.
actually it's actually completely irrelevant. So there's a really funny article that I read recently. It was put out about a year ago now by a wonderful SLP by the name of Katie Gore, and the title of it is "Stop with the Damn Disfluency Counts," and it's a great article. Now it's geared toward SLPs, but I feel like people who stutter would get a kick out of it. Now there is some jargon in there and some things that are very SLP specific, and just some really wonderful insights that are pulled from current research. And so and it's kind of the final point I'll make about this in terms of just the assessment. So if I'm comparing, I'm thinking about two particular instruments that are used for assessment. There's one that's called the stuttering severity instrument, which is meant to measure the frequency of stuttering and the events, and et cetera, et cetera. And that's what gives you like that percentage or whatever. Like, okay, so then you compare that percentage to another like a population of people who stutter, and you kind of come up with a number, and then you can say like, there is like moderate stuttering occurring, and this is the type, and blah blah blah, which in no way is reflective whatsoever of the person's experience. So that's kind of like just a raw numbers. Now, any SLP worth their salt is not going to be focusing on just that. They're going to have an interview and everything else. But for me, I'm kind of with Katie Gore on this, in that it's largely clinically irrelevant. Like you could take away that portion, and it's really like and if you kept everything else, like the interview, and really focusing on the speaker's perspective and everything else, that this percentage, whatever it is over here, has no effect whatsoever on our goals in therapy for me. And so to me, it's essentially irrelevant.
Mm.
And I think that's the point that she really brings up throughout this article, is with the disfluency counts and the kind of the SSI kind of approach, is that it's largely clinically irrelevant. Now, on the flip side, you have something else that's kind of become, I think, what I'm assuming anyway, just because of the popularity of it. Also, Katie Gore mentions this in the article as well, is that there's something called the OASIS, which is this stuttering assessment instrument that's called the Overall Assessment of the Speaker's Experience of Stuttering. And what's great about this is that it essentially focuses on what that person is feeling internally, and it's not dependent on the external listener's perception. So, for example, the problem with the SSI is that I'm listening to you speak, and I'm listening for those stuttering events, but that is irrelevant. That's not telling me anything about how you feel or whether stuttering events are happening and you're just hiding them or avoiding the word, or there's covert kind of more stuttering occurring. So the overall assessment of the speaker's experience of stuttering, the OASIS, kind of just does away with that old school approach and is really shifting it towards the speaker's experience. And so that's kind of considered the gold standard starting point now, in addition to like combining in with an interview and everything else, because really that's where the focus should be. Because I've met people who stutter, I've worked with people who stutter. I recently did an assessment for an adult who stutters about 2 months back. And even though, yes, they were stuttering, they actually felt really great about their communication. They felt really good about it. But if I had followed, an old school disfluency count and sort of saying like, well, there was 20% of, disfluencies and it's moderate, to severe or whatever. And if I just focused on that information and didn't account for the speaker's experience and saying they actually felt really good, about what was going on, then to anybody reading that report, it would really skew the results. And it would also be a big disservice to the client, because we're not really focusing on what's most important to them. At the time, they only really needed an assessment for personal reasons. It was something for school, basically. They just needed something for school. And so, if I had just kind of ignored that and really pushed a lot in kind of using that, old kind of perspective, we would have missed out on a lot of information, but we also would have just been way off the mark in terms of what it is that they actually really needed, which turns out wasn't really much of anything. They just needed an assessment. That was it. But otherwise, they felt great. So, and I'm more than happy for them. That's what we want to hear. That's the goal. That's what we want to hear.
That's excellent, Terry. Terry, following up on what we're talking about now, like mental health and counseling. As an SLP, you mentioned in your bio that that you have a strong interest in the emotional realm of stuttering, which is obvious. It's quite obvious now.
Yeah.
But I'll read you something now that I would like your feedback, and we'll ask you some $64 questions, okay, related.
Okay. Sure.
Mental health is an important issue for everyone, but people who stutter often have specific areas of concern. As evidence, stuttering can cause certain emotions and can have negative effects on one's self-esteem and outlook. People who stutter are predisposed, I feel, to mental health issues, as identified in a 90% below the surface of the emotional and psychological realm in the stutter iceberg. And Terry, I'm also being very honest here. I feel that Joseph Sheehan's numbers, 10% as the tip of the iceberg, as well as is the physical characteristics of stuttering. The 90% below the emotional realm, below the surface, is 90%. As a person who stutters with years of yesterday's of stuttering experiences, I feel the tip of the iceberg is 1%. Below the surface is 99%. That's Greg O'Grady talking here. So anyhow, for many people who stutter, it can feel daunting to speak, and many social scenarios are made difficult, and this can have an adverse effect on mental health. Anxiety is a common issue for people who stutter, who may find speaking causes anxiety, frustration, and stress, which can often exacerbate into wider mental health issues. Anxiety, depression, and fear avoidance of social interactions often follow each other, And when either goes unchecked, things can greatly affect mental health. But most people stutter, these feelings associated with their disorder are an important part of the problem. For some, they are paramount. So, when you listen to this as an SLP, how would you factor in this into a clinical treatment of stuttering?
Yeah, and that's an excellent question. In fact, that is the question. Um, because if we're thinking about the starting point, kind of, so let me back up a little bit. So there's kind of three from an assessment perspective, and if we're taking into what consideration what you just said, the number one top of the list thing is the internal experience that we should probably start with in terms of like how we're, whether if we're going to observe and just kind of take a tally and kind of analyze what's going on, the internal experience should be top of the list. Below that, we're kind of looking at like sort of like the intensity of the stuttering, like how severe is it, and that also ties into the experience and how severe they feel it is, and also just how often it is, the frequency of the stuttering. Um, and really, the internal experience is kind of so interconnected to those other two that really it's really just necessary. You have to start with the internal experience. And so if we're starting with the internal experience at the start of an assessment, then everything you just stated in terms of depression, anxiety, all of these other factors have to be things kind of on our radar. It's not an assumption that I ever make with a person because you can meet a person who stutters and they feel great about how they communicate, and that's wonderful. But like you said, there can be that sort of predisposition or a likelihood of that just based on life experiences and sort of things occurring um, as a result of the stuttering. So yeah, um, I would. I mean, in terms of just like what I would do in assessment, like with an interview and everything else, there's certain things like questions I might ask and I might probe a little bit deeper, depending on what the responses are. Um, and it would start all the way back in terms of like I might we might look at how that person's experience with communication was when they were really young in elementary school. We might start that far back. We might talk about, do you have parents who stutter? What's their experience? What's their attitude toward it? What's their interpretation of what stuttering is? And so I think that the like aside from kind of like probing around those questions as well, is that from that you can actually kind of get an idea of what the person's perception or understanding of what stuttering actually is. And so I think that that's a really important question that you can kind of investigate and sort of figure out together in that initial interview. And you can it can be very illuminating. So for example, because there's such a strong psychological, I don't want to say component, but strong psychological aspect of stuttering in terms of the experience and things that can occur in the person's communication experience in life. Um, Kind of have to think about like, do they know? Does this person understand or know like why the stuttering is occurring? It's not just because of the psychological aspect of it. I don't know if I'm making sense at all right now,
Mm-hmm.
but what I'm kind of getting at is that there's sort of, and let me say this actually from the person who doesn't stutter perspective. There's kind of a big misconception, and this is something that I'm sure you've experienced yourself, and maybe you can speak to this a little bit, where people who don't stutter assume that a person who stutters, is doing that because they are anxious or because they're distressed or because they're feeling depressed or whatever the case might be. There's some they feel like it's all in your head
Mm-hmm.
basically.
Mm-hmm.
um, and so that can be a big problem and a big challenge, I should say, in therapy, because if the person who stutters is seeing you and that's kind of their understanding of what stuttering is, that's something you really need to nip in the bud right away, and make sure that the person has clarity as to why stuttering is occurring in the first place. And that can have a profound effect on the internal experience. And kind of circling back now to your original question, and sort of tying that to the assessment portion. And so if you can shift and sort of help that person understand why stuttering occurs, and why, like, why do people stutter, that can have that big shift. And so there's just so many other factors that tie into it. Like I was saying previously, is that based on experience as a child, based on input from parents. It could be that maybe you had somebody had a father who stuttered as well, and they just said, well, you just got to do it and get over it, or oh, it's just something you'll never be able to, it's all in your head, you just got to think your way out of it, kind of thing. And it's maybe that's been their perception, and they kind of pass that down. And so I think that's what makes stuttering so complex, is that, and because there is often a familial component to it, that there's all of these factors, emotional factors, that kind of tie into that core experience of the person who stutters. That, yeah, it just, for me, it's like, as a person who loves a challenge, and wants to be kind of at ground zero with the person helping them, and kind of helping them make these connections. It's a challenge I welcome. It can be tough sometimes, but I've seen, fortunately, even though I'm not a very experienced SLP, I've seen people on the other end, when they have made these connections, and when they have actually seen, like, oh, like, this is really, like, I understand my internal experience now. Like, I'm actually seeing why like, why stuttering happens, and they all of a sudden, it's like this domino effect, where any guilt, depression, anxiety, everything else that they ever felt in their entire life, all of a sudden just starts to make a little bit more sense. And that can be really exciting. If you're not addressing that as an SLP, and if you're not considering that as an SLP, then I think that's a disservice to the person who stutters, because everything else is so contingent on that. Your goals, your even just your assessment of the person who stutters. Anyway, I'm rambling a little
That's
bit.
okay, Terry. I'm listening.
Yeah, but no, yeah, but feel free to jump in, and like, if you feel that, like, if there's anything in your experience, because you can speak to this as a person who stutters, is that I feel like, if you're seeing an SLP these days for a stuttering assessment, these are all things that they're going to be thinking about and talking about. I'd say, like, the vast majority are going to be thinking about these things and working on these things. I feel like maybe 20, 30 years ago, probably not. There's probably more emphasis on those, disfluency counts and those things I was kind of talking about before. That's why I think things like the OASIS assessment, and really focusing on that person's experience, is just so core to that 99% of the iceberg that's below the surface. Because we can't reliably measure, at least from a listener's perspective, if I'm just observing person, I can't reliably measure moments of covert stuttering, which are like kind of the hidden, this sort of like the hidden stuttering that occurs, whether somebody's changing a word, or what. We might be able to catch it now and then, but we're never going to be 100%.
Terry, why is it that why is it that many of the speech language pathologists, let's say, there's this information out there. I mean, the words on the street, let's say, that many speech language pathologists avoid taking on people who start clients, because of the emotional component is so deep in everything that you see. And I would be curious to find out in Newfoundland how many speech language pathologists have people who start as clients, which I question there's not that many. But why do you think, Terry, that SLPs, even new graduating students or students in speech pathology are so
Hmm.
leery about taking on people with stutter.
I think, yeah, it's funny. Like I know, I mean, it could be just based on my experience and like the students, like in my cohort. We all loved our like we had like a class like that was solely focused on stuttering, and it was great. We all really enjoyed it. I think like that was kind of the overall consensus. There might have been a few people who maybe weren't super into it.
Of
I
course,
can't speak for them. Yeah, but I think you aren't incorrect in that. I've spoken to other SLPs where there might be a reluctance to work with folks who people who do stutter because there's just a lack of knowledge or a lack of um, ability in terms of training or awareness or practice with techniques. So you can look at, and I'm even just talking from a treatment perspective in terms of like stuttering modification or fluency enhancement techniques, and sort of like the what we could call like the bag of tricks that we might have in our at our disposal to use in a treatment session. So sometimes it could just be that. It could be that the SLP simply doesn't have experience or maybe training in those areas, which is fair. For me, for example, I don't have a ton of experience working with, children with autism, for example. And so, like, I wouldn't consider myself a go-to SLP for, to be working with children with autism. I would probably recommend some SLPs who are more specialized in something like that. I would work with a child with autism, absolutely, but if I'm thinking about kind of like best practices and sort of what's best for the client, I might work with them initially and then send them to somebody who's like highly specialized kind of thing. So I think that there could be a misperception as well with SLPs that actually do have the ability and training to work with somebody who stutters, but they kind of see it as something that's like this whole thing unto itself. This whole thing that's like, oh, it's like you need to be a specialist in order to work with people who stutter. And so I don't necessarily agree with that because I was a student working with people who stutter, and we got really good results. And so I'm thinking about my clinical placement at the Miller Center, and generally we things went very well there with clients who stutter that I was working with. And so I think that that could be the one thing is that this sort of misperception that it could be a technique thing, and a skill set thing. Um, that second part, though, that tying into the kind of counseling or emotional component, that's a more tangly one that I don't really. I'll be honest, I don't have a real answer for. I could theorize as to why. I could say like maybe somebody would be more reluctant because of those emotional components. They maybe feel that their counseling skills or that they're not able to offer what the person really needs, or maybe they feel that this person might not. They might not actually be looking for they might not be looking for what an SLP can offer, which is like treatment methods or techniques and strategies, like fluency enhancement and things like that. They might not actually be looking for that. They might actually be looking for just therapy, to talk about their experience, to kind of work on those things with somebody who's trained specifically in that. And so I think it hits an interesting point is that with an SLP is that if we're kind of thinking about communication and the counseling component of stuttering in our lane, at what point is referral necessary to a specialist? What I mean by that is not an SLP specialist, but a psychologist, social worker, some mental health practitioner who maybe works with people like that. And I know in this province, there's, I mean, I don't know. Like I'm curious about like, are there any mental health practitioners in this province that specialize in working with people who stutter? And I think that's kind of the big question that
and
I have
Terry,
too.
this is a big question I have as well. It's a
Okay.
huge question because you see as a person who stutters. I mean, the focus I still is often on the clinical, the tip of the iceberg treatment of stuttering, but for
Yep.
some reason or another, the mental health component below the surface
Mm,
is a taboo, and you also mentioned it as well, because the actual emotional component of stuttering is so deep, so many layers to it. Because as you mentioned, many of us are going back to the developmental area of studying in childhood,
yeah,
and so really, I mean, that actually takes a skilled person, and God bless all speech language pathologists. They do have they do have a foundation to discuss the self-esteem issues, the lack of confidence, the
yep,
challenges associated with the actual physical component of stuttering. But
yeah,
when it's a deeper level, that's a whole different kettle of fish. And unfortunately, within the province here, and I'm being honest here, because I
yep,
actually retired in 2017, and 2017, and moved back, and I was looking for support for people who stutter in our
yeah,
province, and I was surprised that there was little support out there for people who stutter, and so little was known about stuttering, and now I realize more and more less understanding and attention is paid to the emotional component, and
yeah.
this leads into my next question, which you really have in one sense answered it. As an SLP, when do you decide for the need to invite other clinical professionals, such as a psychologist, psychiatrist, social work, into the collaborative client relationship? And does that often
Yeah.
work? You see, when would you, as a SLP, decide it's time to bring in somebody else?
Yeah, and again, I feel like that for me, it would be when the counseling becomes less about the communication component and the stuttering experience as it relates to that, and more about the trauma, or more about the depression, more about the anxiety, and that's kind of the sole focus. So if I have difficulty in session, um, focusing on the treatment goals that I have as an SLP and kind of steering things toward that direction, that might be when I'm like, okay, we maybe need to bring somebody else in to help out, because um, my skill set only goes so far in terms of my scope of practice, only goes so far. I can't assess depression, I can't assess anxiety, um, but in if I were going to be working with a psychologist, or if I were going to be working with somebody else, and I have worked with other other professionals and in other contexts, and it's been great. It's been absolutely wonderful. But yeah, it's difficult, and it is really dependent on the person's willingness to participate and explore and entertain those ideas about working with somebody else in tandem with working with an SLP, and kind of, and it could be too that sometimes, like, maybe you have a client, and a person who stutters, and they want to work on stuttering modification or fluency enhancement strategies or whatever. They want to work on these things, but it could be that they're just not there. They're not in that place right now. That it just feels so overwhelming. So it could be that maybe seeing somebody for a few sessions, like a psychologist or a counselor, might actually be the better, and then to visit back when they feel like they're ready to kind of tackle that a little bit, because it can be really overwhelming. I think the key problem that I could see happening from a collaboration like that is that if there isn't enough communication between the SLP and the mental health practitioner in clarifying what stuttering is, that could be tricky, and that could lead some folks down sort of the beaten path a little bit. And what I mean by that is just, and I'm kind of just saying this as an example. If you're working with a psychologist who maybe doesn't really fully understand what stuttering actually is, or the etymology of what stuttering is, knowing that there's a biological and genetic component, there's environmental, there's psychological, it's very multifaceted in what actually causes stuttering. But if you have a mental health practitioner who maybe has that sort of person who doesn't stutter, like kind of understanding and thinking, oh, it's all in their head, or oh, it's anxiety. Anxiety is causing the stuttering, or oh, it's the mental health component that's causing the stuttering. They feel like that's the root of the stuttering. And if that's the case, that can really, I feel like that would really divert treatment away from what's really needed and probably send it on the wrong path. Um, does that kind of make
Mm-hmm.
sense?
Mm-hmm.
Where if you have, it's kind of like this: if you had somebody, if all you have is a hammer, then everything looks like a nail. It's kind of like that saying, if you, I think I remember there's a saying too. It's like a doctor said this before. It's like, if you go to a pizza guy, he's going to make you
Mm-hmm.
pizza,
Mm-hmm.
right? And so you have to make sure that, and I'm not knocking psychologists or anything like that, and I'm being very broad and general here. I'm sure there's plenty of psychologists who would absolutely agree, and like, yes, they understand that stuttering is more than just being in your head. They probably, there probably are. But I'm saying in those cases where where there is that misperception, is that if there's too much focus on the anxiety, if there's too much focus on the mental health component, we're kind of ignoring the fact that there really is a biological and genetic, like there is evidence. We have tons and tons of supporting evidence that shows there is a biological component to this, and that stuttering occurs because it just occurs. It's not wrong or bad, it's just there. It's just something that's there. And so it's not necessarily addressing all of the anxiety and mental health components so that it just disappears. It's also about shifting the speaker's perspective in a healthy way and hopefully helping them reach that point where they can kind of see it for what it is. And so I think that those two things need to work in tandem. And that's where I feel like the collaboration between SLP and psychology or a mental health practitioner would really come into play, because my job as an SLP is to help shift that perspective, is to kind of help make sure that we're really focusing on the speaker's perspective, but that we're addressing that in a healthy way, that we're making sure that we're driving that in a healthy way, but that the focus isn't so overt on on the 99% below the surface that we're kind of losing sight of what stuttering actually is, of what the person's experience stuttering actually is. So yeah, it's a fine
Mm-hmm.
balance. But I do think, just back to your original question, I do think it becomes really important to consider including a mental health practitioner if it looks like that's something that starts to stray outside my lane. And also if the person expresses, and even just tells you that, this is, I just need something more, like I really need to talk to somebody about
Mm-hmm.
just this. Yeah.
Terry, let's talk about the F word for a minute, okay? which which is the fluency. Is
Yes.
fluency a better?
Yes. No. But funny, and like, I'm glad you brought this up.
Oh, no,
You
no,
go
no,
ahead
go
first,
ahead.
because I've got. Oh, well, I was just gonna say, yeah. Okay, so like here, I'm guilty of this. I am so guilty of saying this, because like the F word, as you put it. This is really interesting because, and I've read about this in several different articles too. Is that it's kind of, it's not really, and you let me know your thoughts about this too. I'm curious. You definitely let me know your thoughts. I really want to know what you think about this. It's not really inclusive, about, with like, in terms of like people who stutter, or like it's not really inclusive of the full like stuttering experience. And so it's kind of misleading, and it kind of paints sort of this weird binary where and, it's very black and white, where you know we have this cycle, um, and I'm kind of paraphrasing a little bit from an article I read as well, where it's, it kind of just constantly pits that person who stutters against this sort of thing that is just, I don't know. It sort of just perpetuates this kind of false narrative that we've built up about what the goal of even stuttering therapy is, or something like that, for example. So I feel like the word fluency is, it's very tangly. I think the argument for using it might be, it helps us clarify between the moment, like between the difference of like, typical speech and stuttering speech. But like, you could literally just say like a stuttering event versus a non-stuttered speech, you know. So yeah, I don't know. It's a bit of a tangly term
Mm-hmm,
in
mm-hmm.
that sense. But I don't know what what are your thoughts though? I'm really curious to know what you think about
You see,
this.
when I when I started speech therapy years and years ago, they see my whole
Mm,
focus because I always classified myself as a severe person who stuttered. My speech was terrible. I actually couldn't say my name without exhibiting the secondary characteristics of stuttering. Because I
yep.
remember, I mean, it's amazing what stays with you, Terry. Because I remember the worst experience I had with stuttering, and the reality hit home how severe my stuttering was when I was asked my name one time, and as you mentioned before, I classified myself as an expert covert stutterer, and I
Right.
always try to mask my stuttering. And I remember that someone asked me my name, and I was in a group of people at the time and they didn't know I stuttered, but I was so anxious and everything and all the build up, all the emotions, the anxiety, stress. Anyhow, so when I was asked my name, I sort of point, and I knew I just couldn't say it. So I started to point at the ceiling. I said, look now, look now, look now, look now. And this is one of the secondary characteristics of stuttering. So I pointed at the ceiling, look now, look now, look now. The listener, everybody started to look up at the ceiling and it was wondering what's going on. Was Greg having a stroke or something? And then I actually did this for about a minute, and then finally I sort of blurted out, "My name is Greg." So that's how severe my stuttering was. So to answer your question, when I went to speech therapy, I was desperate for fluency. I wanted to rid
Okay.
myself with the fluency, and because I thought
Right.
if I could eliminating my stuttering, all my stress, anxiety, whatever would dissipate. But now I feel when someone goes to therapy looking for fluency, they're going for all the wrong reasons. I prefer the word management.
Yeah. Yes, that's I like that
Yeah.
word. Yeah,
Oh no no no.
continue, please.
Management
Yeah.
is
Yeah.
more realistic, and mind you, see, it's still fluency management, but but you really have to factor in the emotional component. You can sort of
Yeah.
find I can easily go to you, for example, say, Terry, I'm having trouble saying my name. I'm having trouble in introducing myself. So certain situations that cause me even more severe anxiety. What can I do to what techniques can you show me, teach me to how to say my name? So I think that's more
Mm,
realistic, and I think the rest will
yep.
come. But there's also has to be dialogue about well, Greg, what's causing all this? It's the emotional component again. Yeah.
Yeah, absolutely. Yeah, and I think you hit a really great point in there, and that like I love the word management because I think that realistically, like what we're looking for if when we're working on things like stuttering modification, fluency enhancement strategies, all those things, we're really looking at like a reduction in those secondary behaviors. We're not necessarily looking for like fluency is like we want like, of course like that would be wonderful, but realistically like the only another great quote about stuttering is the only consistent thing about stuttering is the fact that it's inconsistent.
It's
You
so
know,
fluid, Terry. It's
and
so fluid. I have my good days,
it,
and no matter. I mean, I've
yeah.
learned speech targets, but all depends on the emotions as well. You know.
Yeah, absolutely. And so I think that yeah, if we're looking at the approach as being as we're sort of managing and also just making the experience of stuttering just more positive and just actually physically just feeling better, as well is that I think about a client I was working with last year during my final clinical placement, and we were working on things like one of the experiences that this person in particular had was that everything just felt really tense and really just like they were fighting, like they were just fighting with their speaking and communicating. A lot of tons of covert stuttering occurring as well, where a lot of changing in words, a lot of pausing, and a lot of things occurring that they just felt really uncomfortable. And following treatment, they just said things just felt less tense. And that was the primary goal in that particular instance. We just wanted things to just feel better. we weren't really focusing on whether something was stuttered or not. We kind of just like, and there were even times where we would even just kind of remind one another, it's like, don't worry, but like the stuttering happened. We're not focused on that. We're focused on the tension. We're focused on the fighting. We're focused on the reaction to it. And we were able to mitigate those kind of secondary characteristics of that tension and everything else. So I love the term that you used was management, because I think in the past, back in the day, there was a really big push on like, you just speaking fluently, and that can sort of, I mean, it's kind of like, I don't really know what the equivalent would be, but it's just really not fair. It kind of creates this really unfair dynamic, or I don't know, this sort of, you're placing something really unfair on the person who stutters, because it's not a
Mm-hmm.
realistic goal for, like, I mean, I'm not saying it's a wrong goal, but it's not a realist. I just don't think it's a realistic one. I think more realistic would be to focus on the speaker's perspective and really honing in on that, and how they feel about their own stuttering and how they interpret it, and just painting this kind of black and
Mm-hmm.
white, fluent, not fluent, can really exacerbate those feelings of inadequacy, or feeling like you're never going to just reach the top of that big hill. It's kind of like, you don't go through therapy and like one day, oh, all of a sudden I'm fluent now, like I don't need to worry about it anymore. It's like, no, that's not how it
Mm-hmm.
works. And I think as a therapist, if that's what you're kind of focused on, you're absolutely doing a disservice to your
Mm-hmm.
client. So yeah.
Terry, if I asked you as a non person, I mean, as a person who does not stutter,
Hmm.
what does it feel like to feel normal?
I know, right? And it's like, like I just don't think about it. It's because, like, there's moments of regular, um, like getting caught up on words and things like that, but like I don't think about it. There's an interesting way of putting this too, and I'm referencing another article I read, where we kind of think about moments of stuttering as like being something that's kind of like a speed bump versus like a big roadblock. And so you can have a moment of stuttering that's like feels like a little bit of a speed bump, but otherwise doesn't really affect communication. And so you could have a whole bunch of speed bumps, but really it doesn't affect communication a whole bunch. But if you have somebody who's like a mild stutterer, and they have one big roadblock every 30 seconds or something like that, it could feel incredibly severe to them. So yeah, I think that's where that kind of interest. But back to your original question in terms of, yeah, like I have no frame of reference for it,
Mm-hmm.
and I think that's what's interesting too, is that, it's kind of like, it's sort of like the fish wondering how a bird flies. I think I'm always going to be endlessly fascinated by the bird that's flying, but that's not going to stop me from trying to understand it, or trying to be better in how I speak about it, or really trying to just shift my perspective.
Mm-hmm.
Um, yeah, it's tough. It's
Yeah.
really tough, but I think that's what really just drives me and draws
Mm-hmm.
me to
Yeah,
it.
and like I feel it's important to ask oneself these questions. For example, as I was saying,
Mm,
as a person who stutters, I often ask myself this question: what does it feel like to be normal? Because normal people don't wake up in the morning wondering about, well, when is this phone going to ring? What uncomfortable
yep.
situations do I have to tend with on a
Yeah.
daily basis? But I think it's important to ask yourself the question, and just then ask yourself, what tools do I need, or what can I do, or what supports can I get to help me feel more normal, whatever normal is.
Yeah. Yeah, absolutely. And you hit a great point in that, thinking about like all of those little things, like it affects every single, like it affects so much of your day to day. And it could completely change, like it just changes everything. It creates that domino effect throughout
Mm-hmm,
someone's whole day
mm-hmm,
in terms of somebody who does stutter. And so yeah, and I think that you hit a great point, and like, what can we do to shift that so it's more streamlined, so it's more akin to the person who doesn't stutter. And I think really it does come down to perspective shifting. It really does come down to how does the person who stutters, like how does their experience affect their day to day, and what can we do to treat that? And I think if you can answer those questions, and if you can really keep that primary question in mind in the treatment process as an SLP when you're working with a client who stutters, then that will not lead you astray. You will eventually get to a point where it becomes just a little bit
Mm-hmm.
easier in those day to days. It becomes less about micromanaging every single thing that you're
Mm-hmm.
doing to avoid the moment of stuttering. But it all comes back to that internal
Mm-hmm.
experience. To me, that's always top
Oh,
of the list. Internal
definitely. Well,
experience.
well, Terry,
Yeah.
when all is said and done, it is a definite quality of life issue. You know what I mean? It's a quality
Yeah.
of life issue,
Absolutely.
and so
Yep.
as I mentioned earlier, I feel Dr. Sheen's numbers are wrong when he about the stuttering iceberg. 1%, and that's me. 1% of the tip of the iceberg is 1%, and
Yeah.
99.9% really is below the surface. So
Yeah.
Terry, I'm watching the time here, and I'm going to end off
Yep.
with one last question. I've got many more questions to ask you, pages and pages, but I think we'll
Right
have
on.
to do a second part of some sort of
Sure.
law. Uh,
Oh yeah. Sure.
Terry, just one more. As we know, there are three types of stuttering. Okay, there's the and
Yep.
there's the developmental, neurogenic stuttering, and psychogenic stuttering. And there's multiple causes like family history, family dynamics, neurophysiology, development during childhood. It's interesting enough. I
Yep.
always thought that for some reason I thought that my my that my stuttering fell into the developmental type of stuttering because my father stuttered. I have four other
Yep.
brothers that stuttered, so there's a heavy genetic component.
Yep.
Whereas you see, then I remembered, and this I haven't thought of this for years and years, that I was hit by a car, and so I was thrown over the hood of the car, and
Oh my.
then my head hit the hydro pole. I was in a coma for 24 hours. So I'm wondering now if, and my sister said, Greg, before the accident, I didn't stutter. So, as an SLP, what would you do with something like this? How would you assess me, or assess any
That
client?
is Yeah, that is really that's fascinating. I'm sorry you went through that, by the way. That's awful to hear about. It's really interesting. And I'll be honest, I don't have an answer.
You don't. I'm
But
surprised.
but but what I would do, my first thing would be to look at and see what types and what was your experience growing up. Was there a point, was your stuttering persistent into adulthood, or did it dissipate after a particular age? And following the event, was it an immediate shift to severity, or was it gradual, or like, so yeah, there's a lot of questions that I would need to kind of probe around that. But that is absolutely fascinating. I'm sure also not totally unheard of in people who stutter. I think I recall reading somewhere about a person who stutters, who had developmental stuttering, but felt that by it was like age, at a very young age, had kind of stuttering went away, and then developed Parkinson's disease and developed stuttering as a result of that. Now it's possible that changes in the brain or changes any trauma or anything like that could shift things around. I know that in addition to the things that you listed about the kind of biological component, genetic component, and everything else, that as I recall from school, I'm being very non-specific here, but there's actually, and even in developmental stuttering, they've done brain scans where it shows that um, pathways in the right hemisphere. I'm trying to remember. I can't remember all the specifics, but essentially that they were less well developed um, versus those who don't stutter. And funny enough, and that those pathways had absolutely nothing to do with intelligence, nothing to do with anything else except the stuttering, basically. So it could be that maybe changes in the brain, maybe if it's developmental over time, and it seems to dissipate, but then it comes back. It could be that changes as you get older cause those pathways to reemerge, or something like that, due to neuroplasticity or something or other. But yeah.
Well, Terry. I mean, this is another huge conversation we will need to have.
Yes, absolutely. And that last question you asked too, like, now I'm going to go down the rabbit hole of like reading papers and stuff like that, trying to find out, like, because I don't have a proper answer, and like I got to get the answer. I have to get an answer now. So I'm going to go talk. I'll tell you what. I'll go talk to some people. I'll see if I can find a good answer for you, and I'll get back to you on that.
And to add to this is I also come from a very challenging family environment, so that adds into the three types. You see, yeah.
Right.
So
there you go.
So Terry, before we close, do you have any last thoughts to share with our listeners? Any thoughts?
Not really. No, I'm super thankful to be here. I get excited talking about stuff like this. So I apologies to your listeners if I rambled a little bit. I love talking about this from kind of the clinician perspective. But yeah, I'm just absolutely pleased to be here, and I think what you're doing with the podcast and the LSA is wonderful. And yeah, I'd love to come back sometime.